Our session is delivery room stabilization and transfer. And this has been organized for us by the Ministry of Health in collaboration with SEED Global Health. So we appreciate you all for sparing your valuable time to be with us this day. And before we start, I would love to introduce to you a few of the persons that are going to be guiding us through this day, this time. We're going to be together in the 2 hours. And among these, we have neonatologists. We have a neonatologist by names Dr. Victoria Nachivuka, who is a consultant neonatologist at St. Francis Hospital, Zambia. And we have Dr. Immaculate Mirembe, an associate pediatrician who will be helping us in the questions that we all will be putting in our chat box. And we also have Dr. Nampija Sisi, a team lead of neonatal resuscitation at St. Francis in Zambia. And we also have Miss Allen Ndagano, midwife at St. Francis Hospital, Zambia. And myself, I'm by name Mbowa Ronald, who will be your moderator through this session. Thank you so much for all joining in. So, right about now, we are going to have some polls. And also, we'd like to know what your expectations are for this session. As you know, we proceed, we'd love to know what you'd love to achieve. You'd love to know, you'd love to unlearn, you'd love to, remember. Just feel free to chat. Just put those expectations into our chat box. We'll be in position to read them. Thank you. So we have a pre-test also already displayed, and we see people are, trying to answer, and that is an apneic newborn has not responded to sanctioning, drying and rubbing the back. What is the appropriate next action? So I encourage you to keep tapping also to what you think could be the best option. Just tap, we'll be seeing, so far I see only like 4 people have tapped in. Just continue tapping, continue. Continue giving your answer, please. Yes, continue tapping. Thank you so much. Thank you. Yes, we proceed, please. Continue tapping to what you think could be the next action. Yes, continue. Thank you all that are complying. Yes. Okay, we can continue, please. So far, around 25 have answered. Yes, continue. Also, feel free going to the chat box and putting in your expectations. Thank you so much for all that I've answered. And now we'll have next question. But still, I encourage you to keep posting in our chat what your expectations are for this session in particular. We can close that. Okay, thank you so much. Thank you so much. You keep having our expectations flowing into the chat. We would love to hear from you as you also hear from us from this end. Thank you so much. At this very moment, I would love to welcome Dr. Nampija Sisi, a team lead neonatal resuscitation at St. Francis Nsambia Hospital, who is going to be presenting us a case in line with this particular session of the day. Thank you so much.
Good afternoon. Thank you so much for joining into the discussion. My name is Dr. Nampija Sisi, and I'm going to be taking us through the cases that are going to be in relation with what we want to talk about today. So we are going to have two cases, one with the birth asphyxia of a term baby, and then we also want to look at an extremely low birth weight preterm to see how we stabilize and prepare for these deliveries. So for briefly about the obstetric history, this was a 38-year-old NM who came in as a gravid 2+1+0, came in from home in active stage of labor with a 2 days history of reduced fetal movements. So an assessment, she was at 8 centimeters with moderate contractions, arm was done, and we noted that she had meconium grade 3 and fetal distress with a fetal bradycardia of between 170 beats per minute. So the decision was made to do an emergency cesarean section, and the mother was informed about the plan and consented to that decision. The pediatric team, or what we call a neonatal resuscitation team, was informed and preparation was done. So under preparation for resuscitation, we went through our equipment checklist, prepared the equipment required for resuscitation. And in brief, in terms, we have baby packs, we switch on the radiant warmer, suction, and bulb syringes, ambibags. They were checked and tested the functionality, masks of appropriate size, oxygen, prepared warm transport. Those are our exothermic mattresses, our Milus, and NICU was informed about possible admission. So briefly, this is the baby. So we noted baby of NM who was born on 18th of May 2025. He was a term male baby who was delivered by emergency cesarean section, secondary to a non-reassuring fetal heart rate or fetal distress. And this baby had a fetal bradycardia of between 70 to 100 and meconium grade 3. So intraoperatively, we noted that this baby had an impacted head in the pelvis, and this made the delivery difficult. So we delivered a blue baby who was floppy and unresponsive with a birth weight of 3.2 kilograms and scored 2, 4, and 7 at 10 minutes. So this baby required extensive resuscitation in the delivery room. Baby was warmed, positioned, suctioned, dried, and stimulated. We initiated positive pressure ventilation for about 5 minutes, but we did not gain spontaneous breathing. So we intubated with a 3.5 millimeter ETT and continued PPV for about 4 minutes. So here, baby gained spontaneous breathing. We extubated and initiated this baby on a CPAP via neopath at a PEEP of 7 centimeters of water. So at that time, our vitals were, a baby was saturating at 96% on CPAP, at a pulse rate of 155 beats per minute, at a temperature of 36.9, and a respiratory rate of 76. So our NICU was informed to prepare to receive this baby with probable mass and HIE, and later we transported the baby to a neonatal unit using our MILU, or what we call our warm transport, or an exothermic mattress. So on transfer, we noted that this baby had 2 episodes of convulsions that were characterized by upward rolling of the eyes with hyperextension of both the lower and the upper limbs. So in examination, the baby was pink, was less active, was afebrile with a temperature of 37.1. He was not pale, he was not jaundiced. However, he had hypoglycemia of 1.6 millimoles per liter. So in respiratory, he was tachypnic with a respiratory rate of 70 beats per minute. He had a SAS of 2 out of 10, saturating at 99% on bubble CPAP at a PEEP of 7 centimeters of water. He had equal air entry bilaterally and chest was clear. So CVS had warm extremities, capillary fill time was less than 4 seconds, and had a heart rate of 145 beats per minute. Heart sound 1 and 2 had normal. So CNS, our head circumference was 33.1 centimeters. Our anterior fontanelle was normotensive, sutures were well apposed, had a partial moral. The sacrifice was just biting, had a poor grasp, and he had hypertonia in all limbs. So we did what we call a Thompson score, and at that time it was 9 out of 22. And per abdomen, it was normal for soft and no palpable organs with normal male genitalia. So the impression at admission was a term baby with moderate HIE, depending on the Thompson score, with meconium aspiration syndrome and hypoglycemia. So the plan at admission was to load this baby with IV phenobarbital, 20 milligrams per kg, which are translated to 64 milligrams. We gave a bolus of IV-D10 at 3 mils per kg. We initiated this baby on therapeutic cooling. We gave IV gentamicin, 16 milligrams OD, IV and Picux, 160 milligrams BD, and we kept the baby on bubble CPAP at a PEEP of 7. So our TFI was 40 mils per kg, and we were giving IV-D10 at 11 mils 2 hourly. The plan was to do a PTI in our APTT blood grouping at admission, and later do a CBC therapy at 24 hours of life. So for the results that were noted that day, the baby had a blood group of A positive. He had a PT of 23.5, which is high, an INR of 1.892, and an APTT of 55.6. So on top of the plan that we had made early, we added IV vitamin K, 1 milligram OD, that was to be given for 3 days, and it transfused this baby with 58 mils of FFPs. So just to summarize the case, the baby stayed with us for about 15 days, and we discharged this baby on 15 days of life. We had managed the baby for moderate HIE and completed 72 hours of therapeutic cooling. We managed the baby for persistent pulmonary hypertension of the newborn on sildenafil and bocetan, which later resolved. We managed the baby for coagulopathy. We've seen our PTs and we kept having increased PTs. So received FFPs 3 times and vitamin K for 3 days. And that later resolved. We managed the baby for neonatal sepsis on IV expen gentamicin, amikacin, and meropenem. Managed hyponatremia, which resolved with saline infusion, had a hyponatremia of 120. And on the 15th day of life, we discharged, and our Thompson score at discharge was a 0 out of 22. And at that time, this baby had reached full feeds, was able to breastfeed with a very good suck. And the plan was to follow up in a neonatal clinic. So as of today, as we are presenting, the baby is currently 3 months. He's doing well, according to the mother. He's able to breastfeed well. He passes stool well. He's very active, and currently he has what we call a social smile. Thank you. So that's our first case.
Yes, thank you so much, Dr. Sisi. I hope all of us were attentive and were able to pick something. So you just feel free to raise any questions into the chat box about the case that has been shared to us. And right now, we will be having another case presentation still in line with this today's session, okay? So feel free to make any questions within the chat box. You will surely be answered accordingly. Thank you.
So the second case is about a mother who came in at 28 weeks. She's NB, a 27-year-old female who came in with an obstetric history she came in as a referral from a peripheral clinic for further management, and she presented with a 2 days history of vaginal bleeding. Reportedly, she had unremarkable antenatal period. She had attended 4 antenatal visits from the referring center, and to note, mother's blood group A positive. So at admission, a diagnosis of antepartum hemorrhage secondary to placenta abruption was made, and a decision for emergency cesarean section was made as well. So the mother was informed about the decision by the obs team and prepared for admission to NICU, and the pediatrics team was informed. So during the discussion, because she was at 28 weeks, she was informed that this baby needs NICU admission because of the extremely low birth weight prematurity. So the pediatrics team was informed and preparation for resuscitation were made. We went still through our equipment checklist, prepared equipment that were required for resuscitation. These are baby packs, switched on the radiant warmer, suction, and bulb syringes were prepared. The ambubags were tested for functionality and as well prepared. Masks of appropriate size, especially for this one is a 28-weeker. You don't really want to use a 20 or a 30 or a 36-weeker for this one. So oxygen was prepared and prepared warm transport with CPAP to NICU. So because the baby was a 28-weeker, we prepared, of course, our warm transport. We transport these babies with exomic mattresses, and the exomic mattresses have what you call insta warmers. So we usually boil water for the insta warmers. The polythene bags were prepared, and NICU was as well informed about the possible admission. So about the baby, it was a baby of NB who was delivered on 6th of April 2025. It was an extremely low birth weight preterm, was delivered by emergency cesarean section, secondary to APH, as we've already stated. Mother had abruption placenta. The birth weight was 860 grams. Babies forward 4 at 1 minute, 6 at 10 minutes, and 8 at 15 minutes, with a gestational age of 28 weeks by Ballard. So at delivery, the baby was blue, floppy, and not breathing spontaneously, and this required resuscitation. So the baby was warmed, was positioned, dried and stimulated, was suction initiated PPV via bag and mask ventilation for about 2 minutes, and this baby gained spontaneous breathing. And later we initiated the baby on CPAP at a peak of 7 centimeters of water. So baby was wrapped in a polythene and put in an exomic mattress, which we call Womilus on our side. So later NICU was called and informed to prepare for an extremely low birth weight preterm with respiratory distress syndrome, and currently on CPAP at that time. So the vitals, the baby was saturating at 98% at a PEEP of 7 centimeters of water, heart rate of 167 beats per minute, and a temperature of 31.7 with a respiratory rate of 56 beats per minute. So we later transported the baby to NICU for more respiratory support and management. So in initial assessment in NICU, the baby was pink, baby was active, baby had no jaundice. However, he had a very low random blood sugar. So per respiratory system, the baby had a respiratory rate of 37 breaths per minute, had a SAS of 5 out of 10. He was saturating at 98% on CPAP at a PEEP of 7. However, had equal air entry bilaterally with bronchovesicular breath sounds. CVS, the baby was warm. As per extremities, the CR2 was less than 3 seconds, a heart rate of 164 beats per minute, heart sound 1 and 2 had a normal. Per abdomen, it was of normal fullness, soft, cord was well ligated, no palpable organs with the normal female genitalia. So CNS, the head circumference was 25.0 centimeters, anterior and posterior fontanelles normal sensils, sutures not opposed, and we did not have most of the reflexes. So the impression was an extremely low birth weight preterm with respiratory distress syndrome and hypoglycemia. So the plan was to continue on bubble CPAP at a PEEP of 7. Our TFI is of 90 mils per kg of D5, which translated to 3.2 mils per hour. What to initiate an IV caffeine citrate, we loaded at 26 milligrams and maintained at 17.2 milligrams once daily. To maintain, initiate an IV Expen, high dose, and IV gentamicin, 4.3 once daily. To give IV paracetamol, 13 milligrams 6 hourly. To do blood grouping, APTT, PT, INR, and to do a CBC CRP at 24 hours. So also, we were to cancel, or we canceled our parents on need for surfactant in case our SAS remained above 5 out of 10, regardless of the baby being on CPAP. So on the summary, this baby unfortunately spent 3 days of life in our NICU. We managed the baby on for respiratory distress syndrome on bubble CPAP, but later the baby was put on mechanical ventilation. We managed this baby for neonatal sepsis. Later we got into septic shock. We gave high dose Expen, gentamicin. We had started the baby into dopamine infusion. Managed the baby for coagulopathy. We transfused with FFPs 3 times and gave vitamin K for 3 days. Managed for apnea prematurity on caffeine citrate, but unfortunately the baby got pulmonary hemorrhage. We transfused with blood and platelets. We had a possible PDA, so we continued with our paracetamol. We had hypoglycemia that later resolved, but the baby was already on infusions of D10%. So unfortunately, on the 3rd day of life, we noted that this baby was profusely bleeding from the UVC sites and also bleeding via the ETT with desaturations, regardless of the baby being on a mechanical ventilation. It was desaturating between 54 to 64% with a pulse rate of 178. So suctions via the ETT were done. We applied pressure on the UVC. We put stay switches. However, the bleeding continued. And we gave platelets, gave FFPs. However, the baby just continued bleeding. So we noted that this baby was further desaturating regardless of the mechanical ventilation. PPV was initiated, we suctioned via the ETT, but we just kept getting desaturations with reduction in the pulse rate to 54 breaths per minute. We initiated chest compressions with coordinated PPV. However, there's no return of spontaneous breathing and no improvement in heart rate. And unfortunately, the baby passed on, may also rest in eternal peace on the 3rd day of life. So that's our second case.
Thank you so much, Dr. Sisi, for such a wonderful presentation and a case presentation that we have all had, and really appreciate the fact that there are lots of details that have been, available to us. And I go through the chat, I see a number of questions that many of us are putting across, and we surely will have to reply to you in the due course, as a matter of the fact that after this case presentation, we are going to have the presentations from different people, and I guess many of these questions actually that are in the chat box are going to be answered. So be well assured, keep on and attentively listen. Everything is going to be answered accordingly. Please, thank you so much. So at this moment, I would love to, I've taken note of all the questions actually. So if many still have any questions in your minds, please feel free, put them in the chat box. We'll surely answer all these questions. Thank you so much. So at this moment, I would like to welcome Miss Allen, a midwife from St. Francis Hospital, Zambia, who will be taking us through on what the nurse's role or midwife's role is in a delivery room in line with the stabilization. Thank you so much.
Good afternoon to you all. I'm Ndagano Allen, working at St. Francis in Zambia Hospital, working in neonatal resuscitation team. So I'm going to take through the delivery room stabilization. And the objectives are assessment, stroke, and identification of risk during after deliveries, in brackets, babies that need resuscitation. Number 2, preparation to receive stroke setting up delivery room, in bracket, equipment check and what to do with the equipment. Okay. Stabilization of newborns, in bracket, new preterms and birth asphyxia and after stabilization. Number 4, assessment points for PPV and what next after. Transportation, inter-facility and intra-facility, in brackets, transportation devices and ambulance. The last one, communication between the team and the parents. Then I'm going to take through number 1, assessment or babies that need resuscitation. Approximately 10% of newborns need some assistance to breathe at birth. Babies needing resuscitation often exhibit, and number 1, lack of breathing. Breathing absence or abnormal breathing, including gasping and apnea or lack of breathing. Those babies who can't breathe or lack of breathing may need resuscitation. Absent heartbeat. A slow heart rate, in brackets, below 100 beats per minute is a strong indicator, especially if it persists despite initial assessment. Then number 3, poor muscle tone. In this, I mean, when the baby is floppy, the activity is 0, that baby might need resuscitation. Then number 5, preterms. Preterms, babies below 36 weeks of gestation may need resuscitation. And number 6, meconium stain liquor. It can be grade 1, grade 2, or grade 3. Those babies, in most cases, they aspirate. But in the first hour or in the first gold minute, you need to resuscitate that baby so that the chances are decreased. Then number 2, I'm done. Delivery what? Delivery preparation to preparation to receive or set up delivery room. Before each delivery, we must ensure that the following equipments are available and functional. So this is what I mean. In the morning, when you come on duty, the first thing you should do, you prepare your things, you make sure that they are functioning, and you make sure you put them in the right place. You prepare your resuscitation kit or your resuscitation tray. Some of the equipments include radiant warmer, or those facilities or the low settings, you may have the flat surface where you put your baby to keep that baby warm. Then number 1, bulb syringes or penguin suckers to suck secretions. And the first thing you should do, you should make sure you use the 4-bucket system. The first bucket you put dick. The second one you put soapy water. The third one, clean water. The fourth one, you put distilled water. You put what? Sidex. And the Sidex, you make sure they stay in Sidex within 15 minutes. No, within 20 minutes. I'm sorry. Then after those 20 minutes, you raise them, you put in distilled water. After distilled water, you put them in a container or a bucket so that they are ready for use. And number 2, pulse oximeter. Most pulse oximeter are rechargeable, and others you just put the battery. You make sure that pulse oximeter is functioning. Then the stethoscope. The stethoscope, you may put that pulse oximeter along the radiant warmer or on your resuscitation tray. Then at the ambu bag, the masks, you make sure the masks for preterm and term babies, for preterm size 0, and for term babies size 2. And number 6, the oxygen cylinder. The oxygen cylinder, you make sure in your delivery room you have the oxygen, and on the transporter which you use to transport babies in NICU or ICU, and then the laryngoscope. The laryngoscope, you make sure that the laryngoscope are sterile, and the blades, you make sure the laryngoscope, the size 0, size 1 for preterm and term babies. Then the Wamilos. The Wamilos, you make sure the Wamilos, you have the Easter warmer. The Easter warmer, how do we put the Easter warmer under the Wamilo? You get your hot water, then you put the radiant warmer inside the hot water. And then the polythene bags, the one we call buveras, but they should be transparent so that you can see the chest movement, or when the baby is breathing. Stabilization of newborns in brackets, preterm and birth asphyxia, and after stabilization. Stabilization of newborns, preterm and birth asphyxia after stabilization. This may involve immediate involves immediate intervention to support breathing. Number 2, heat function, and number 3, temperature regulation. Initially, stabilization within the first hour warmth. Preterm infants are particularly vulnerable to hypothermia. Maintaining a neutral thermal environment is crucial. This may involve using Womilo devices, wrapping the infant in plastic, and ensuring warm room. Then the airway, clearing the airway of secretion and ensure airway is essential. This may involve sanctioning or, in some cases, using laryngoscopes or masks. Then the breathing, if the infant is not breathing or is breathing inadequately, PPV may be necessary. PPV, here I mean positive pressure ventilation. This is typically initial. Supplement oxygen and oxygen saturation. You should make sure you monitor the baby. Saturation. If the heart rate is low, chest compression or immediate medication, likely epinephrine may be required. Then here, the umbilical cord clamping. In the delivery room and in theater, if the baby is out, we might delay cord clamping. But if you want to delay cord clamping, we delay cord clamping in 30 minutes. If the baby is stable, we delay cord clamping. But if the baby is not stable, they clamp the baby immediately. Assessment points for PPV and what next? PPV, positive pressure ventilation in neonatal resuscitation, requires ongoing of several key points, and the most indicator for successful PV is a rising heart rate. In this situation, you may require a team. You can't PPV alone. You need to be a team. And in this case, other key assessment points include breathing effort, chest volume movement, skin color, and the heart rate. A rising heart rate is the most important sign of successful positive pressure ventilation. If the heart rate is not rising, or if it is below 100 beats per minute, ventilation should be continued with a collective steps. Then the breathing effort. Assess for spontaneous breaths and gasping. Respiration, if the baby is not breathing or is gasping, PPV should be initiated. Then the chest wall movement. Assess for spontaneous breaths and gasping. Respiration, if the baby is not breathing or is gasping, PPV should be initiated. Chest wall movement. Observe for chest raise or fall with each ventilation breaths. If there is no chest movement with PPV, collective steps should be taken. Skin color. Monitor for cyanosis, bluish. Here, I mean when the baby is what? Is bluish or blue in color, then PPV should be considered if the baby is not breathing. Transportation, intrafacility and interfacility. Intrafacility means inside the facility, and the interfacility means outside the facility. Objectives: maintain airway, breathing, circulation, prevent deterioration, and ensure safe handover. This, in the first place, you should make sure your transporter is ready to transport that baby, or the Womilos, the pulse oximeter, all the things needed or required. And the intra-facility transport team, oxygen, stroke ventilation, continuously monitoring. Interfacility, warmth, airway, monitoring, and a trained staff. Like in Zambia, all staffs, all the people who are supposed to receive babies, they are trained. Communication between the parents and the team. Ensure to inform NICU or nursery in bracket baby unit, respectively, if necessary. Like if you get a preterm, the first thing you should do, you inform the NICU to prepare so that when you are going to transport that baby, everything is prepared. And before transporting that baby, you should inform the parent, especially the mom. That's all. Thank you.
Yes, thank you so much, our dear Miss Allen, and I thank you, Dr. Immaculate, because as I go through the chat, I see you have really answered almost everything that has been raised in the chat box. Thank you so much. And I believe also all of us in listening to Miss Allen, we have really noted down a lot of things, because as she prepared and projected everything summarized there, and I saw some commenting that you see reading, but that is how she prepared, and that's why she has been presenting to us that way. So we are following the chat. Thank you so much for following also, and thank you, Dr. Immaculate, for answering all the questions in the chat box. So at this juncture, I would love to welcome Dr. Nachibuka Victoria, our consultant neonatologist in St. Francis Hospital, still to take us through the same theme, and that is delivery room, stabilization, and transfer. You're most welcome, Dr. Victoria.
Thank you very much. I hope you can hear me. I'm sorry I'm not going to put my video on. I'm a bit far to ensure that I'm able to heard and I don't have interruptions with the network. I would like to thank the team that has been able to present the case. And thank you very much, Alan, for your good presentation. Alan is our neonatal nurse who really mans the neonatal research room. And she's really very skilled. She can be able to intubate babies actually in the delivery room, given that even if she is a nurse. So Alan, want to thank you very much. And Dr. Sisi, thank you so much for the presentation. Next slide, please. Next slide, please. Okay, I'm going to just give a background. Why do we need to have delivery room stabilization? What is it? Why is it important? When you look at the global data, 2.4 million neonatal deaths occur, and 90% of them occur actually in Africa. And what is surprising, 50% of these babies occur on day one, meaning that you have 1 million babies dying on the first day. Oh, but what are we doing in our delivery room? Have we taught people? Do we have the equipment? Do we have the skill? Do we have what it takes to make sure that our babies are stabilized in the first 24 hours? And birth asphyxia is one of the things that accounts for mortality, about 35%. And usually when babies have birth asphyxia, actually 24 up to 60 to 70% of them die in the first 24 hours. A systematic review then just to look at the timing or the distribution of neonatal deaths. When do they occur? 72nd week and another 11% in the third, fourth week. And usually what happens is that majority still of those, almost 50% of the babies actually occur on day 0. And then majority, and then subsequently you have on day 1, day 2. But the biggest proportion of babies that die is on day 0. But what do we do to stabilize them on that day 0? Next slide, please. Next slide, please. So this is also just another showing when we have the different neonatal deaths. If we say birth asphyxia, prematurity, you still see that birth asphyxia deaths 77% occur on the day the baby is born. Prematurity, 47% occur on the day the baby is born. And of course, the congenital malabsorption, 45%, except for sepsis. The sepsis deaths usually occur a little bit late, usually in the 2nd week and the 3rd week. But majority of the babies, the preterms, the asphyxia occurs on day 0, when the baby has been born. Next slide, please. So in Africa, studies have also been done to look at the timing of the neonatal deaths. A study was done in Gambia, and 57% of neonatal deaths occurred in the first 48 hours. And actually, 48% of these deaths were preterms. And in Uganda, a study that was done by YASA in 2016 reported that 90% of the neonatal deaths in Uganda occur in the first 1 week. However, 52% of these occur in the first 24 hours, with about 37% of them being preterms. A study was also done by Lucy when she was studying baby preterms at Kawempe, 370 of them, and noted that almost 48% of the preterm babies died in the first 48 hours. Next slide, please. So this is just a graph to show for preterms what are the major causes of death among preterms according to the different hours. The first blue thing shows that majority of these babies die when it's extreme prematurity in the first 12 hours. However, when we go to the next 72 hours, the major cause of death among preterm babies is respiratory distress syndrome. And still you can see things like infection, like NEC, they usually come a little bit later. Next slide, please. So this is just showing us the trend of the causes of the early neonatal deaths, okay? So when you can see here that still see birth asphyxia is the major cause of death, and then followed by prematurity and infections. So birth asphyxia has been the major cause of death for the last 10 years. Almost 60% of all our early neonatal deaths is because of birth asphyxia. It's something we must do. We must fix birth asphyxia if we are to reduce the neonatal mortality in Uganda. If we reduce birth asphyxia, our neonatal mortality is going to reduce by 60% or by 50%. Next slide, please. So this is just showing us the proportion of babies that actually are resuscitated on that other previous graph. But although we have like many of the babies resuscitated, why is it that we still have a lot of babies dying birth asphyxia? Next slide. I've talked without. Next slide, please. Next slide, please. So the other thing which causes babies to die very much in our units, and sometimes it's a silent killer, is hypothermia. You can resuscitate a baby, but if you don't keep that baby warm, you increase the risk of death by 28%. For each reduction in one temperature, you reduce the risk of death by 28%. And one of the things that can predict mortality in your unit is the admission temperature in the NICU. A 1-degree decrease in the admission temperature is associated with 78% in increase in mortality. And the highest risk of neonatal hypothermia is within the first minutes to hours after birth, because there is a wide difference between the in utero environment temperature and the temperature outside. When the baby is in the mother's womb, the temperature is 38. The baby comes out, we have AC on, we don't have any warm transport. That baby's temperature is going to reduce within minutes. And once a baby is cold, it's going to increase your risk of hypoglycemia, metabolic acidosis, respiratory distress is going to worsen. So we must pay attention to hypothermia in the delivery room. Next slide, please. So, sorry, this is a bit, but this is just summarizing some of the delivery room temperatures. It talks about the interventions, talking about we must prevent hypothermia in the delivery room. We must pay attention to the respiratory effort. We must be prepared. We must talk to parents. We must have people who are skilled to attend to the babies in the delivery room. It's just a summary of some of the delivery room interventions that we do to improve the survival of our babies. Next slide, please. So interventions to do, this is just evidence. So what are some of the things that we do to reduce birth asphyxia? Resuscitation, neonatal resuscitation training reduces deaths because of intrapartum asphyxia by 30%. And also, once some studies have been done, I think in China, where they had a consistent systematic way of doing resuscitation, where they trained regions and the different regions trained their own teams. They reported there's a reduction in neonatal mortality, and they used the NRP, or the neonatal resuscitation program. And this was done over a period of 15 years. That means we need to have coordinated, regionalized neonatal resuscitation training every year for everybody that is handling a baby. Must be trained properly on how to resuscitate. And then there are things you can also do in the delivery room. CPAP in the delivery room is a beautiful thing. It reduces the need for intubation, the need for mechanical ventilation, and the need for surfactant administration. So some studies still were done in Brazil, where when they started CPAP in the delivery room, reduced the need for surfactant in the NICU by 66%, the need for the ventilator in the NICU by 56%. And then also when you start CPAP in the delivery room, another study in China, there is reduced the need for just any kind of intubation for the baby in the delivery room and even in the ward by 20%. So it is something we can do. It is something that's not very expensive. We can start doing CPAP in the delivery room for our babies. Next slide, please. So if we are to address or improve our delivery room stabilization, we need a bundle. You cannot train a person without giving them equipment, without providing the personnel. Training alone without providing the necessary things may not help. So that's why we are saying we need a bundle of interventions. So a clinical bundle is a set of evidence-based interventions for divine patient population and care setting. When implemented together, result into significant better outcomes than if you implement one thing alone. So I'll give an example. I'm not an obstetrician, the emotive bundle. This was done to address challenges in PPH. I think in studies where it was done in Nigeria, Kenya, Tanzania, and Uganda, they reported a significant reduction in PPH by 60%. So it means we have these interventions, we have to do them together. We train, we provide the equipment, and then also provide the human resource. A neonatologist, a pediatrician may not be able to come to the delivery room, but a nurse, you can see Nurse Allen in our setting. She is such a wonderful person. She's for the babies. She understands the babies. She's able to do a work a neonatologist would have done. And once you train her, motivate her, definitely you are going to get good results. Next slide, please. So why do we need to have a delivery room stabilization? I'll talk briefly so that you can understand. Usually when the baby is in the mother's womb, the placenta is doing the gaseous exchange. It is doing the work of the lung. So the baby comes out and is not breathing. The lung has not been breathing. And this baby needs to be stabilized. The baby needs to be supported during that transition. And we must understand the different steps of the bundle that we must do to make sure that this baby is fine. So that means we must anticipate. We must prepare. We must stabilize and then transfer this baby. In those steps, anticipation, preparation, resuscitate, stabilize, and transfer the baby. Before you cannot transfer baby you have not stabilized to the next level of care. Next slide, please. So what are the components of, I said we must have a designated neonatal resource team. You may not have a designated neonatal resource team, but you can have people that are skilled that you are going to send to especially to the high risk. I'm not saying, I'm going to explain why. So to your delivery room. So for us in our setting, we have a medical officer and midwives, and sometimes pediatricians if we have time. That means I can transfer my skill to a midwife, to a medical officer, to do what I can do as a neonatologist. And these people represent me very well in the delivery room. And that the main thing is the high risk deliveries. And then we have to train them. We have to provide the equipment, okay? And the human resource has to be there. That these three, the bundle has to have the skill, the equipment, and the human resource. And then we want to initiate CPAP in the delivery room. So we have to assess the severity of respiratory distress in the severe room. If it's more than 3, we start CPAP. And we must pay attention to hypothermia, because I said hypothermia increases the risk of death by 75%. Whenever the temperature falls by 1 degree, you increase the risk of death by 75%. So we must maintain warm temperature, have radiant warmers, transport these babies when they are warm from our delivery room to the theater, to the NICUs, to the next level of care we are sending these babies. Next slide, please. Next slide, please. So, every delivery must be attended to by a skilled, trained personnel in resuscitation, whose primary role is to do neonatal resuscitation, not to do any other thing. Why? Okay? Therefore, we must have people with designated in our units. We may not be like us who have a proper, the hospital has supported it. I thank the administration of Zambia. These are posts. We have a post for a neonatal resuscitation team that is filled and they're on the payroll for the hospital. But maybe we may not have this. We need to push this agenda in our hospitals, okay? They must be people who are trained. We don't just get anybody nakuna kanjako to just come and receive a baby, someone who is not trained, okay? And similar to any other emergencies, the best outcome is achieved when a skilled, organized, and efficient response from an effective team and assurance that we have an appropriate response. We must be deliberate in training people. We train people every year on neonatal resuscitation. We train and train and train, and it must be a deliberate practice and for careful preparation. Next slide, please. So what are some of the components of neonatal resuscitation? I know Alan has talked about them. I'm going to just emphasize certain things. Anticipation is the first thing. Before every birth, the neonatal health provider should review the pregnancy history with the OBS team to determine how many babies. Are they multiple? Are they triplets? Is it meconium? Is it IUGR? Is it abruption? Is it a cord accident? Is it a collapse? Because before you go to resuscitate the baby, because you have to prepare, what kind of baby am I going for? Okay. Another thing which can guide us, we can have what we call the list of risk factors. Any baby that is under the risk factors, approximately 80% of them are going to need PPV. They'll need Ambiobag. So you need to look at the risk factors, which baby is at risk for being resuscitated. So we have that actually. That means review the risk factors with the obstetric team before you go to the delivery room. When some studies have been done that when the neonatal team is going to attend a birth, when the pregnancy is considered a high risk, 47% of these babies will need to receive positive pressure and ventilation. That is your Ambiobag ventilation. So we have to know when you're going to deliver. Is it a preeclampsia? Was the mother given milk sulfate? What is that dose? In your mind, you're going and okay, you're saying, okay, this baby most likely may have this. So you're anticipating. And that anticipation is very key and it's needed for your preparation to receive the baby. Next slide, please. So this is just showing you some of the antepartum risk factors that you must look out for before you go to receive a baby. And then the other column is showing you the intrapartum risk factors that you must look out for before you go to receive the baby. If a baby is less than 36 weeks, please go with an Ambiobag. Make sure that you have the warmth. Make sure that you have your CPAP ready. If a baby is more than 41 weeks, sometimes we underlook these babies 41 weeks, but they're the ones who get the meconium expression syndrome. They get persistent pulmonary hypertension. Is it preeclampsia? Is it multiple? And then some of the intrapartum risk factors increase. Is it a breech? Was it fetal distress? Did the mother receive magnesium sulfate? Because sometimes magnesium sulfate affects how the baby is going to breathe, okay? Was there abruption placenta? Was there choriamnitis? They should receive any drug. Sometimes these mothers are in pain. We give them morphine. When you go there, the baby is flat. So we must review the risk factors with the ops team before we go to receive the baby so that we can prepare appropriately for this baby. Next slide, please. So preparation. So after evaluating the risk factors, then you go to, like what Elena said, I'm going to go through, you prepare your equipment. It's better to have a standard checklist to know, because sometimes if you don't have a checklist, you may miss out certain things. Okay, is my Ambiobag working? Is there, do we have our suction? Do we have oxygen? I'm not going to go through all the things, but I want to emphasize every delivery must be attended to by a qualified health worker whose primary role is to manage the baby. I'll give an example. When an obstetrician is going to do a cesarean section, can they do a Caesar without an anesthesiologist? Can they do a Caesar without them bringing a delivery kit? The same thing we should do for our babies. We must have a checklist. Is this person, do we have a qualified person? No obstetrician is going to do a Caesar if there's not an anesthetist. They will not, they'll say, I'm not coming. We should do the same thing for the babies, because you're going to do a Caesar to receive a baby. But the person going to receive the baby last had neonatal resuscitation training in 2014. Really, we must prepare. And we have to make sure that our skills, do we have the equipment? Is the Ambiobag there? Is there oxygen for the baby? Because by the time you find the oxygen is for the mother. Okay? It is for the mother. But for the baby, babies also need oxygen in the delivery room. And then you start running. You are wasting time. Remember, the baby's lung is starting to breathe the first time before the placenta was doing the gaseous exchange. So we must prepare for this baby just as we prepare the scissors. There is a one who receives the equipment, the instrument. There is a running nurse. There is an anesthetist. We must also put on our checklist. Is the person going to receive the baby ready? Is the equipment ready? Is it running before we start doing cesarean section? Next slide, please. Next slide, please. So this is just a summary. You can't resuscitate alone. You have teamwork, you have to prepare. Then you have to talk with your obstetrician. We have to work together with the obstetricians. We need to have a team lead, someone who's going to guide, who is going to get the equipment. When this is not there, who is going to get it? When I need oxygen, where am I going to get it? If I need the nasal prongs to put the oxygen, who is going to bring it? So as a team, you brief each other before you start the research. Just like I think the obstetricians and the anesthesiologists do before they do their scissors. They check, is this coccus here? Is this what they are? Or they always ask, but we do the same for the babies. And once we have done that, then our outcomes are going to be good. Next slide, please. So some of the interventions, I think Alan has talked about them. Warmth. So we have to warm the baby. Positioning is very important, and neutral position is key. Suction where necessary, and then stimulation. Those are the first 3 steps: warmth, position, suction, and stimulation. If your baby doesn't respond, then you go to the next step. I'm not going to waste a lot of time. She's already talked about them. Next slide, please. So this is just showing you the right position. And why am I talking about the right position? You have to make sure that your upper airway and the lower airway actually are aligned together. Okay, so that the photo in the middle up here and the one in the middle down is the right one. Sometimes either we overextend and sometimes we overflex. So once you flex, then the upper airway and the lower airway are not aligned together. So positioning of the airway is very important. Next slide, please. So yeah, I think positive pressure ventilation, that is doing ventilation with the ambiobag. Any baby that does not have respirations after the drying, stimulation, and suctioning, we usually do our positive pressure ventilation. Okay, next slide, please. Or we ambiobag our babies. So this is just a photo showing us how to do the ambiobag. Where do you place your mask? Where do you place yourself, by the way? You can see, you can either stand, okay, at the head, so that there's space for the other person to do any other thing. So this is the correct position when you're doing our bag and mask ventilation. Next slide, please. So when do we intubate? I know this is a mixed population. We have pediatricians. We also have other people that may have some of these things. I think in most of our levels of care, we always do PPV, we always do ambiobag ventilation. That is beautiful. If that is all that you can do, please, if the baby is not improving, you can call for help, or you can send that baby to the next level by doing your bag and mask ventilation. Studies have found that the most important step in resuscitation is the bag and mask ventilation. So for those that are able to do the extra in our settings, this is a guidance for you. When are you going to intubate? You always intubate if your baby is not improving, oxygen saturation and heart rate are not improving on your bag and mask ventilation. And if you want to do your chest compressions, and if your baby actually already needs things like adrenaline or epinephrine, you should do your intubation to improve the ventilation so that baby's heart rate can improve. Like what Alan said, one of the things to show that you're ventilating very well is when the baby's heart rate actually improves. Next slide, please. So this is just a photo and a landmark to see what are the things that you see when you are trying to intubate the baby. What are the landmarks? Next slide, please. This is when you do chest compressions. The chest compressions, you do them if your heart rate is less than 60 beats per minute, despite your 30 seconds of doing positive pressure ventilation. So don't start by doing chest compression. Next slide, please. So this is just showing us how we do the chest compressions and how we also do the ambiobag. This is just a photo. We are just going through. It's an education, not a practical session. Next slide, please. So when do we give epinephrine? Or sometimes we give drugs. So you give drugs if your heart rate remains less than 60 after 30 seconds of assisted ventilation with an ambiobag, plus 60 seconds of doing your chest compressions and your ambiobag. So that's when you qualify to give your drug like epinephrine. Next slide, please. So the other things, after you've done your ventilation, you have done your resuscitation, you have the initial steps of warmth, stimulation, and suction and positioning, you do your PPV. So, and then sometimes after that, we want to stabilize this baby. Some of the things that we do is the CPAP in the delivery room. I want to emphasize it. Like many babies less than 34 weeks require respiratory support. So to prevent injuries caused by mechanical ventilation, less aggressive ways to provide respiratory support have been designed, okay? And the recent evidence supports early CPAP for management of respiratory distress. Actually, this has been incorporated in the recent neonatal international resuscitation guidelines that we start CPAP at delivery. If you finish resuscitating the baby has labored breathing, baby is grunting, instead of just carrying the baby running to the NICU, please start your CPAP in the delivery room. Let's go to the next slide, please. So why CPAP in the delivery room? If you start it early, it establishes improved lung volume. Remember, this baby has not been breathing, okay? The more time you use, the lung collapses. It establishes lung volume and avoids the need for intubation, okay? And then also, whenever we ventilate babies, we increase the injury to the lung, okay? It is for this reason that CPAP must be started early in the delivery room for babies, for preterm babies with respiratory distress syndrome. Next slide, please. So, yeah, continuous CPAP has been proven to be beneficial in reducing the baby's need for ventilator. And how many units do we have ventilators in Uganda? You just count them, whether private, whether government, they're on your hands. How many babies are delivered in Uganda? If we only have 4 or 5 units that can offer ventilation, we can use CPAP. So when we start CPAP early, reduce the need, okay, for ventilator. And the aim is to improve the lung volume, okay, and decrease the work of breathing and avoid apnea, okay, and avoid actually the need for ventilation. Studies have been, there is a lot of overwhelming evidence for us to start CPAP in the delivery room. Next slide, please. So, and I think I've already talked about that. Next slide, please. That's just the evidence. Next slide, please. So, actually, there's been consensus. There's been consensus that has been put that based on the studies that there is evidence that CPAP started soon after birth is a strategy that appears to reduce death, chronic lung disease, and is an alternative for prophylactic or early rescue surfactant approach. How many people can give surfactant? And I think the only cure we have for these preterms is CPAP and providing warmth, okay? Infants treated early with CPAP instead of early are not at increased risk of having surfactant, okay? So it is the best evidence, the most recent evidence with a caveat of babies who develop respiratory failure and require intubation or ventilator care. So once you want the babies in the delivery room, keep the baby warm. Start CPAP early in the delivery room. Next slide, please. So this, I put this as I know this is not like we had yesterday lecture, it's not, but you can get these these images on 5 parameters that you can use to assess the severity of respiratory distress syndrome. So you have to look at your upper chest, your lower chest retractions, the xiphoid, the nasal flaring, and for me, why I like it, a nurse can use it, okay? Our nurses in our units use it comfortably, okay? They can tell you, so you have if it's mild, moderate, or severe. So you just look at the severity of the retractions and the xiphoid retraction, and then the grunt, and then the nasal flaring. Next slide, please. So any baby between 3, with a SAS score between 3 to 6, please start CPAP. And any baby is less than 1.5 grams, many times there are high chances of having RDS, start CPAP in the delivery room. And those that have a Silverman-Anderson score of more than 6, that are apneic, their heart rate is less than 100, this one need to be intubated and given surfactant. And that means if you don't have that in your setting, probably continue doing your PPV, your bag and mask ventilation, make sure the baby is warm, and refer the babies, go with the babies to the next higher facility. Next slide, please. Next slide, please. So this is an algorithm. I hope it's a bit clear, that shows us that we need to start managing. How do we manage RDS in the delivery room? You have your initial resuscitation. Make sure the baby is warm. Warmth is key very much. So you start your CPAP at the delivery room, you start your PEEP at about 5, but you can maximize your PEEPs up to about 8, actually. And then if the baby is apneic, has poor respiratory effort, despite what you've done, this baby needs to be referred to the next level. You need to intubate, ventilate, and administer surfactant. And then if the baby has good respiratory effort, the heart rate is not dropping, you can maximize your PEEP, okay, from 5. I know we've been taught 5, but I think the recent guidelines, the European guidelines are saying you can maximize up to 8. The issue is to avoid ventilating this baby. And those, if you have your blender, if they require a very high amount of oxygen, any baby with a SAS score of more than 6 and is already maximized your CPAP, heart rate is dropping, this baby needs to be ventilated and intubated. So if you don't have those, please kindly do your bag and mask, call the next person, the doctor, someone who can help you, and then refer the babies. But we must pay attention to warmth of these babies in the delivery room. It's very, very important. Warmth is a magic bullet that is going to improve the outcomes of these babies. If the babies are cold, even if you tube them, they're going to die because they're cold. We hear the word as attend to thermal regulation in the delivery room. Can we have the next slide, please? Next slide, please. So thermal regulation, wow, it's the next one. So thermal regulation should be avoided during stabilization and upon admission. Why? It worsens hypoglycemia. Cold stress affects actually the pulmonary vascular tone, okay? And the baby is actually, the surfactant production is going to reduce. That means you're going to worsen your RDS. And then you can also have metabolic acidosis. And finally, this may worsen your respiratory failure. So we must ensure that we keep these babies warm. Next slide, please. Next slide. Okay, so what are some of the strategies to reduce hypothermia? One, we must make sure that our delivery room temperatures are 23, 26. Please, obstetricians, tell obstetricians, we don't want the AC, or the AC must be set at 25, where the babies are comfortable. Then any baby less than 28 weeks or less than 1.5 should be wrapped in a polythene bag. Polythene bag is Kavera, but the transparent one up to the neck as they're being delivered, or sometimes these babies don't need to be read, especially the 28 weekers, because they're so sticky, okay? They have fluid, okay? And if we can afford, I'm not saying this is the standard, please, 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 don't say Dr. Nachibuka said this. If we can have actually the exothermic mattresses, we also recommend to use them, okay? Even when at delivery, you put the exothermic mattress on top of your radiant warmer and the Kavera, especially for babies less than 28 weeks and below, and you do your resuscitation steps if you have them. If you don't have, well and good, put your Kavera as you're resuscitating them. And then skin is really very good for babies who are stable, actually. If you don't have a radiant warmer, just do skin to skin, even as you're doing your resuscitation. Next slide, please. Next slide. So why am I talking about thermal regulation? Because it increases mortality. Okay, admission temperature is a predictor of neonatal mortality. For each degree fall of that temperature, you increase mortality by between 28 to 75%. Sometimes these babies just need to be warmed nicely. Okay, next slide, please. Next slide. So, when you finish resuscitating, you've done your CPAP in the delivery room, you've started it. How do you transport your babies? Warm transport from the delivery room to is one of the key components of the warm chains. If a baby is not kept warm from delivery at the postnatal ward or even the neonatal ward, it's associated with significant drop in the temperature, even if the temperature at birth was normal. Okay, so we must make sure, as some studies have been done where they have noted that yes, prolonged postnatal hypothermia after transfer from the labor wards okay, to even with from the level that the radiant woman just transfer the babies. So it's important that we must ensure during transport, okay, from the delivery room to the neonatal unit. This is very, very important because it's going to affect the outcomes of your baby. A baby reaches the NICU, they're 34, they're 35. It's worse than the respiratory distress. So these babies, we need to keep them warm as we are transporting them. Next slide, please. So we have a Womilo. You can use, I'm not here to market because this is what we have, but there are certain other, this is an exothermic mattress. An exothermic mattress means that it's able to retain heat, okay? And then when you need to just press a button and the heat is generated in a safe mode. It has been used to accommodate preterms and it is used, we use it for transport. It has an InQ blanket and an instant warmer. Instant warmer is like a gel that is able to, those gels are able to keep the heat. We get the instant warmer, we boil it, and then we store it. When we need it, we just activate a button on the instant warmer, and then we put it within the InQ blanket so that we want to protect the baby from being so direct to the heat. And this can maintain heat up to about 3 hours. So we use it for transport from the delivery room to the nursery, but also when you are transporting babies to other hospitals, sometimes some parents cannot afford in Zambia. So we get the baby on CPAP and we also wrap the baby nicely and send and transport these babies. So it is something that can be adopted by any unit. There may be other exothermic mattresses. I think there's Embrace at some time. I don't know what happened, but for us, we have the Womilo. We can, I always tell people to avoid using gloves. Sometimes babies have been burnt in my unit because sometimes the monitoring, I know we try to innovate. The other thing is doing kangaroo. If a mother, and it's difficult if a mother has had a seizure and then she's transporting and doing kangaroo, if you can get a surrogate to help do the transport for KMC, transport these mothers, babies in KMC when you're transporting them from one unit to another to maintain the work, because hypothermia significantly affects the outcome of these babies. Next slide, please. So I have talked about it. Next slide, please. So this is our warm transport. I think I'm not even there. So we have the small bed. We made the small transporter bed. On it is embedded our CPAP. We have a neopuff, but a bubble CPAP that you can do. And then we also have a pulse oximeter. So this is one of our doctors, Dr. Sisi. She's transporting a baby from the delivery room to the nursery. You see, this baby is nicely wrapped up in the Womilo. The other health worker on this other side you see this oxygen is embedded here on the transporter. And then you have the baby wrapped up in Womilo and the baby is also on the CPAP. So this is something that we do for stabilization after research. Pay attention to the respiratory rate, pay attention to the warmth of the baby, and even how you're going to transport the baby is very important. It affects the outcomes for these babies. Next slide, please. So what is evidence? Of course, we have done this for over maybe 7 or 8 years. We have been able to scale it up in a few hospitals. I think now it's in 5 hospitals, but I'm happy other people are also doing it. I think I've seen the people in Mulago, I've seen the team in Chisenyi, which is good, okay? So our team basically is made up of, we have a designated neonatal research team, 1 medical officer and 2 midwives. We train. I think I love training. We train people every year. We have CPAP at delivery, warm transport, and then also we have the equipment. It's been done in 3 hospitals in 3 years. So our sample size is quite big, 7,736. Next slide. So this is just a summary of some of the results we've had. And they're very, 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 I love them. They're so good. So it reduces birth asphyxia by over 50%. So the post-intervention, 3.3 babies had 3 birth asphyxia. Post-intervention on 0.7%. HIE, so reduces the proportion of babies by HIE by over 50%. Hypothermia on admission reduces over 60%. And then when you look at the need for CPAP, all the world also actually reduces by over 50%. And the need for the babies to be admitted in the nursery also reduces by over 50%. And also the need for surfactants. So it is something that really, if we do it well, it's going to have a lot of impact. It may seem like expensive, but if we have birth asphyxia has been the cause of death for the last 10, 20 years, what is it that we've done differently? I know some people say it's obs-gyn, but we also have a role, as Dr. Sisi presented. Some of the babies score so poorly, but if you have a good research team, you can stabilize these babies, and the babies actually can get better. You can have improved outcome. Next slide, please. So thank you very much. These are nice, lovely babies that we're managing now in our unit. And thank you very much for listening.
Yes, thank you so much, Dr. Victoria. The passion behind all these words that are coming out of you really drives us to really love what we all, are doing in our facilities out there, and adding on this knowledge that you have really passed on to this wonderful team here. I believe many changes can really happen if we really also put in action the message learned here in our facilities with that passion, making that checklist for the equipment, having the warmth prioritized wherever, starting CPAPs in the delivery room. All these are very wonderful things that we all really would embrace. And I thank you so much, Dr. Victoria, for that amazing presentation. So right about now, I think Dr. Immaculate was handling the different questions in the chat box. And I don't know if Dr. Immaculate, you would love to answer certain, some of the questions. Maybe you would love to maybe, verbally echo out some aspects, because I see all questions that were in the chat box were tackled. So Dr. Immaculate.
Yeah, thank you so much, moderator. And thank you so much to all our presenters. This is very wonderful. I'm Immaculate Mirembe, pediatrician, Mubende Regional Referral, and I've been in the chat box. Thank you for being active. And the questions kept coming in. And there were no very specific questions. I think there are about 3 things that kept coming back. How do we know this baby needs oxygen? And that has been answered, but I'll ask Dr. Victoria to re-echo on which baby will need oxygen, and how do you determine whether I'm going to give free flow and or CPAP? That question came up. And then someone asked, is everyone, when Alan presented about the equipment, she talked about laryngoscope, and someone is asking who is allowed to use a laryngoscope. I tried to answer, but you can also add up. And then the pertinent question, which has come back twice, Dr. Sisi, you presented about a preterm who didn't make it, but had actually been stabilized. And the question is, what else could have been done for this baby to survive? What happened? Why didn't the baby make it, yet everything was done well? And then someone also asked about the same baby. Giving surfactant, could it have helped to help this baby survive, probably in the delivery room? I think that's it for now. Back to you.
Thank you, Dr. Mirembe. I think we'll pass over to Dr. Sisi to answer a few things. Yes. All Dr. Victoria, please, as far
it's okay. Okay. I would like to thank the team, I think, for Seed Global for organizing this. I think it's a very good thing, very good attendance. And I want to thank everyone that has been able to attend. I'll just start with CPAP. I think we have guidance, and the SAS score, a Silverman-Anderson score, is something that you use in the low-income countries, and I think it has been used in Brazil because it helps us to assess the severity of respiratory distress, okay? And it is a very easy tool, and maybe we shall have one time a video on how to assess a score. I think maybe we can organize a webinar for that, just 30 minutes. So you look at the recessions, how the baby is recessing, okay? We have the subcostal recessions when the chest is going down. Then the intercostal recessions are in between the ribs. And then the xiphoid recession. Specifically for preterm, the xiphoid, that middle part is going to go in. And then nasopharynx. And then you're going to assess to see if this is mild, moderate, or severe. So each of them is given a score of 1. If it's less than 3 or less, please give these babies free flow oxygen, because we are all struggling with CPAP. You're not going to put every baby on CPAP, okay? And even if it's between 3 to 6, you give CPAP. If it's above 6, that is so severe, that baby probably in your unit, if you cannot give surfactant, if you cannot intubate, that baby needs to be referred. So maybe we can have a CPD on how to assess a score. We can have a video on assessing score. The other thing I'd forgotten is grunting. Grunting is that noise where the baby is doing in Luganda they say omwana nga akema Grunting is a sign of severe respiratory distress. You can't just give a baby that is grunting only free flow oxygen. That baby actually qualifies to start on CPAP, because the upper airway actually is closing, or the lower airway is closing and the upper airway is trying to open, okay? So it's a sign of severe respiratory distress. So once you have that severe grunting, chest indrawing, severe nasal flaring, some of those babies you need to give CPAP. If you only give free flow oxygen, the babies are going to just worsen. And then there was another question on another question, I think on laryngoscopes. For why we include these laryngoscopes, because some of the people attending here are in level 3, but if in a district hospital where they are not, that's okay. You don't have to have the laryngoscopes, okay? But the level 3 NICUs, the people who are able to intubate, we encourage the neonatal team to intubate. Yes, anesthetists can intubate, but it's also good for us as neonatal people learn how to intubate. Who is allowed to intubate? Probably a pediatrician, medical officers, anesthetists that have been trained on the skill of intubation, actually. Some nurses, I think, do intubate, but if they intubate, they must be in presence of people who can intubate. Like I know Alan can intubate, but Dr. Sisa is there, I'm also there in case she's struggling. They must be under a seniors or who can guide on the intubation. Concerning that baby was a bit complex. Even if we had given surfactant, this baby got a complication called pulmonary hemorrhage, bleeding from the lung. And sometimes these babies bleed from the lung. They bleed from the lung. And then it's a complication that sometimes it may be difficult. Even if we did what we wanted, even if we did the research, even given surfactant, may have not reduced, maybe improved the outcome, because the baby had a complication in the lung and also had an open duct, that is pattern ductus arteriosus. Sometimes these babies need to be operated immediately, which circumstances we don't have. The heart has a hole. So we did our best. But never, despite the fact the baby died, we must resuscitate these babies in the delivery room. We must be able to provide warmth, do whatever we can to help these babies, even if they may have other complications. I think that is it. I hope I've been able to answer all the questions. Thank you very much, everyone. Thank you.
Thank you. Thank you so much, Dr. Victoria. I think I am actually seeing other questions in the chat box. Like some colleague has asked, like, how long will you go on with the neonatal resuscitation in an unresponsive newborn? So Dr. Victoria, maybe you can also help on that.
Well, I think people say about 30 minutes, but I think the NRP says that I should do it for about at least 10 minutes. If there's have no heart rate, then you should stop. If the baby has no heart rate, 10 minutes. Some people talk about 30 minutes. But of course, there are challenges. For example, if the baby has a heart rate and is not breathing, if the baby has a heart rate and is not breathing. If you're in a place where you're able to do ventilation, please refer that baby to the NICU. But if you are not in a situation where you're not able to ventilate, it may be impossible. So do it about 30 minutes and stop. And the other thing is, the important thing is to communicate. Gentle communication to the parents is very key. Letting them know what is happening and what you're doing. Because if you communicate with them, you're like preparing these parents that, you know, we are doing our best, but they may survive and may not survive. So communication is key when we're doing some of these things. Thank you so much. I can see Dr. Immaculate has a hand.
Yes, thank you, Dr. Victoria. Sorry, Chair, I impeached you, but I would love Dr. Vicky to answer this. How do you proof yourself from causing barotrauma, both in resuscitation and oxygen? I think it's important to answer this. It's also from the chat.
Okay.
And then someone is saying, can we use locally made CPAP, our improvised CPAP? We don't have the standard equipment. Thank you.
Okay, so how can we prevent ourselves to have barotrauma? Our colleagues abroad they have a neopuff. When you set up the neopuff, you set the pressures, but most of our ambubags actually do not have the gauges. But please don't go above 25 or 30. Those the ambubags that have actually the gauge. Please, when you're bagging, should look at the gauge of how much you're bagging, and then also there is a rhythm you must use when you're bagging, depending on where I trained. Like I think where I train, what I use, the NRP says breathe, you squeeze the bag, 2, 3, release it. Breathe, 2, 3. Breathe, 2, 3. Okay, that's very, very important. Sorry, what was the other question? How can you? That is how you can prevent barotrauma. Then oxygen.
The use of locally made CPAP, the available CPAP.
I know.
The presentation, they didn't use that.
I may be a bit controversial, but I'm a person who believes in innovation. And even before in Zambia, before we got all these things, I think I was one of the people who promoted the improvised CPAP, because to be honest, till when we can have it, we can have these other CPAPs, then we are telling me, I think we can still go on as long as we teach people properly. And I think Dr. Anita has done a nice video on how to use it. I know sometimes people fear pneumothorax and all that, but we don't have them. So until the other thing is the VIO, if we can have the VIO around, the VIO CPAP, we can use it, can also use it for transport, but I still say we can still use the improvised CPAP, in my opinion, given the fact that we don't have these things. We are going to continue pushing, but we are telling people to use CPAP. They don't have. So the improvised CPAP can be used, but maybe we just need to continue maybe saturating those videos to show people how to do them, because all of us started from there. From Mulago, we went to Zambia, we are using the improvised CPAP. Now for us, we are lucky, we are able to have the good CPAPs, and still the hospital doesn't provide through advocacy, through collaborations. That is why we have everything. So I still think we are saying CPAP in the delivery room. Let's use the improvised CPAP as we continue advocating for the right CPAPs in our regions. Thank you very much.
Yes, thank you so much. Thank you so much. Yes, Dr. Immaculate, I see. Is it Dr. Immaculate?
No, my hand is down. Thank you.
Okay, please. Any questions from the audience? Who would wish maybe to put their hand up and maybe ask some questions? So far, I don't see any hand up, but I see some questions in the chat box. Like people are asking about where do we get this Buvera that we are talking about? Is there any specific type? How does it look like? And I see that where do they buy them? So, kind of questions are here. Also, some people are asking if there are any resuscitation videos, like videos about resuscitation, maybe that could be shared to them. Then what is the fetal hydrop, the fetal hydrop?
Hydrocephalus.
Yeah, so I think, Doctor, you can help in answering a few of these about the Cavera and
Sorry, about the question of the polythene bags, as doctors explained and Sister Aline have explained that they have to be transparent. And I think for us, the ones currently that we are using in our resuscitation units or resuscitation centers is the transparent. We have a sister who acquires them from downtown and she brings them in big numbers. But I think the quality and if you go to Nakasuri to Kawempe, the team will tell you can even use the foils for those ones that are extremely low birth weight return because of their very fragile skin. But the issue about it is that they have to be transparent such that even when you provided good warmth, you still are able to see the response to your resuscitation. So that they shouldn't be colored so that you are not able to see whether you're giving good PPV or good resuscitation in terms of chest rise, and also be able to continue with assessment of the heart rate and the rest. I think that's the question about where we can acquire and which kind of polythene bags we use.
Maybe just to add, like these Boveras, they use for the delivery, when you're going delivery kit, the consistency. Instead of them being yellow, you can get the same as colorless. So especially for preems, those babies who are less than 30 weeks, you really maintain the warmth nicely. And if you're transporting these babies from your lower unit to the other, we can wrap them and put CPAP in as you transport these babies. Because really hypothermia is a silent killer. It doesn't shout. But once a baby has hypothermia, the risk of death multiplies by, I say, 28 to 75%. It's a silent killer. It's silent there, but it's doing havoc to your baby. Thank you. Dr. Mirembe, I think has a hand.
Yes, I have a hand, and it's in relation to a comment someone has answered. Someone was asking, how long does the CPAP have to be in place? And someone said 10 to 30 minutes, if no pulse, then no need. I just wanted to clarify that we do not give CPAP to babies who are not breathing. Please don't give CPAP to babies who are not breathing. The baby has to be breathing, has got the bag and mask, he's now breathing, and then you can put the CPAP. And then Dr. Vicky, you have a comment. When is the next delivery room preparedness training in Zambia? Thank you. Back to you.
Okay, thank you. Well, okay, we usually organize this once a year, but maybe we may organize some, because it's a very I think those who have attended it, it's very practical. You really have hands-on on everything. It's not the theory. It's 3 days actually of resuscitation, CPAP, warmth, and we really do. Being a clinician, I love we give the theory and then the practical bit. And usually many times when people leave, many of them are really changed. So we shall organize, we can let you know, maybe in November or December. We can do a 3-day, and maybe we can tag a small fee to it. If people are promised they can attend, then why not? We will go even to the delivery room, and it's very nice. Actually, many people have learned how to intubate from that course. It's very practical. 3 days, but basically resus, CPAP delivery room, and warmth. Very practical issues with the theory with it. Thank you.
Thank you, Doctor. Thank you so much. Also, I think this goes to Dr. Mirembe, also Dr. Immaculate. That is, someone has asked, may you briefly explain on how the local CPAP is made? I see it in the chat also.
Thank you, Mr. Moderator. I think someone has shared a link There's a team in Women's Hospital led by Dr. Anita. She's a pediatrician neonatologist in training, who made an improvised bubble CPAP, and she has shared a link. That is the best way for you to learn. We cannot really explain how to make CPAP, but maybe the mechanism of CPAP. I want to send this back to Dr. Victoria. Why CPAP and not nasal prong oxygen? I think that is the question people are asking themselves. That difference, I tried to explain in the chat, but probably didn't come out very clearly. The advantages of CPAP versus free flow oxygen to these babies who are not stable in the delivery room. Back to you.
Yeah, there's a difference, and I still think these people need to attend this training. Let's try and see if we can have it November or December. So when a baby is breathing, when you breathe in, okay, you increase your pressure, okay, your lung capacity. So everybody, can you breathe in? When you breathe in, the pressure increases in the what? In the lung, okay? Can you breathe out? Everybody breathe out. So when you breathe out, okay, the lung capacity also does what? Decreases, okay? So for these babies who have not learned how to breathe and who don't have enough surfactant, it means at the end of expiration, the lung is going to collapse on itself. But remember, the heart is beating all the time, and it's getting oxygen from the heart, from the lung. So now, when the vessel, when the baby needs to get oxygen from the lung, and now the heart and the lung has collapsed, what do you think is going to happen? So continuous positive air pressure means that you have pressure in phases of inspiration and expiration, so that it prevents the lung from collapsing, because these babies don't have surfactant. The surfactant is the one which prevents the airway from collapsing. So that's why we are saying we must start it early. When we start it early, that means the lung volume, okay, and the capacity of the lung to collapse is reduced. The proportion of babies that will get apnea when you start CPAP in the delivery room, it is going to reduce. I don't know whether that is clear, but people need to attend this training. Maybe we shall work with Seed Global again to organize this delivery room stabilization, plus really a very comprehensive neonatal resuscitation training for people to appreciate what we are saying. Thank you.
Thank you so much. Thank you so much, Dr. Victoria. Really appreciate. Thank you, Dr. Mirembe, also for answering the questions in the chat box. And I think many of the questions that I see right now in the chat box have been answered. And right now, we would love to go into our kind of post-test. So as we did the pre-test, so we'd like to have now the post-test. There's kind of same questions for us to answer, which are going to be displayed right now.
These are the same questions.
So we can try to answer them accordingly as per the knowledge we have achieved through this time. Just answer one, then you scroll and continue answer the second one like that. I can see. You scroll. So you can keep scrolling and answering those different questions, please. I encourage you. For the time being, as the questions are being answered, we request our expert, Dr. Victoria, to give us some remarks as we come to the end of this session.
So I thank you very much. I would say SIP Global for amplifying our voice to improve newborn care. I think SIP Global is amplifying people I may not be able to reach, but through SIP Global, we're able to reach. I mean, we've had about 260 people. Thank you so much for being very innovative. And I'm really very passionate about this topic because I've seen it work in our unit. It's surprising how the number of babies that need surfactant reduces by 50%. We hardly actually ventilate babies. Now when our postgraduates actually come, they struggle to get babies to tube. It's really, really something that is very, very good. And we really are trying to echo and voice that as Uganda, I think this is the direction to go. Let us improve delivery room stabilization. Let's not leave it let's not leave baby. I mean, these nurses who are not trained, someone doesn't know what to do to go and receive a baby. I think it's very unfair to the mother that has been carrying the pregnancy for the last 9 months. If the obstetrician cannot use anybody to help to give anesthesia, why do we get anybody to receive the baby? I think that is the message. If only trained people can perform cesarean section, why do we get anybody to receive babies? I think that's a bit unfair. So it's the message we are speaking out there. Let us improve delivery room stabilization. And I believe it's one of the keys and one of the strategies that can reduce neonatal mortality in our country. Thank you very much.
Thank you. Thank you so much, Doctor. I think on those remarks, we can't add anything. But at this moment, I request all of us to put on our videos and we will take a screenshot of everyone. So kindly just put on your video. We'll be in position to see you. Just more, put on your videos. Many videos are off, kindly.
Oh, nice.
Yes, keep putting on your videos. Good, that's great. Yes, thank you. Thank you so much for attending in such huge numbers. We appreciate your time, your valuable time, and also the resource persons that have really helped us to go through this session. We appreciate all the preparation. I know you took number of days to prepare for just 2 hours. And I really appreciate the efforts, the tireless efforts we all put in to have this day a success. We call it to an end. Thank you so much, and may we all have a blessed evening.
Mm.